Well, thanks for the invitation back home. I was at Columbia from 1977 through 85 full-time and part-time through 88, and taught here from 82 to 88, and I got my PhD here in epidemiology. Zena was my thesis chair, and also did my pediatrics here from 1977 to 80. Imagine coming from my master's degree studies. I did my pediatrics, then I went to do public health master's degree in London. Imagine coming back to New York City in September of 1981. And Anna Gelman was poised to retire. And she was the only infectious disease epidemiologist at Columbia. But thank God, Waffa, that's not true anymore. You have a whole raft of talented people. But back then you were told, don't go into infectious disease. That's a dead agenda. Chronic is where it's at. And we were especially strong in neuro epi and psychiatric epi. And we were, leading lights in chronic diseases. We had strong cancer epi and the like. But since I really care deeply about developing country issues, of course I thought that was nonsense, and I had no intention of not doing what I was interested in doing, infectious disease epidemiology. But little did I know how immediately relevant that would be in the city of New York. I had seen the MMWR about this odd new immunodeficiency, and it kind of looked like an infection to me. And people like Waffa and Marianne and others, we were all together in this mix here at Columbia. Waffa was doing her ID fellowship at NYU and came to do an MPH. Marianne came to do her MPH and then her DRPH. Tom Frieden was my student. Salim Abdul Karim was my student. And I could go on with the star quality of the people who actually took an interest in infectious disease epidemiology at that time. And to be a young assistant professor at Columbia with the kind of talent that was coming through this institution was truly, someday I'll write a memoir, it was absolutely extraordinary. And whether it was working on malaria in Nicaragua with the Sandinistas or whether it was working on HIV right here in town, there was a vibrant, and that tradition of vibrancy, look at ICAP, for example, now, and look at the global reach of Columbia infectious disease prevention control is just mind-boggling. So I really am pleased to be back home. What is treatment as prevention? Well, there were two papers back in 2000 and 2001 that found lower viral load correlated with far lower transmission to sexual partners. That was directly leading to the famous HPTN 052 study that Mike Cohn and colleagues published in New England Journal, their preliminary findings and their ultimate findings. So it took a while to actually get from the observation to the completed clinical trial, but at the end of the day, the field needed the trial because they were not going to transform policy without stronger evidence that treating an individual reduced their infectiousness to a sexual partner. It's really quite similar to the concept of PMT-CT, prevention of mother-child transmission, because you're treating the mother, reducing the viral load, the baby doesn't get infected. You're treating the sexual partner, you're reducing the viral load, the partner doesn't get infected. So the fundamental concept of reducing the infectiousness of one person to protect another has been around for a long time. There were also ecological data from Vancouver on expanding treatment and lower transmission, and also from KZN, which were intriguing, not definitive, but intriguing. This was the second study. Quinn was the first, and this one's not as well known. This was our study from Zambia. And we did not see a single transmission under 3,000 viral load. So these were discordant couples being followed by Susan Allen and her cohort. And there was a threshold below which there were no black dots, if you will. Now, fast forward many years, 15 years, and you ended up with 4 large studies of treatment as prevention with HIV endpoints. The ANRS trial in KwaZulu-Natal, the Yatsea trial, otherwise known as the Botswana combination prevention program, the SEARCH study, and the HPTN 071. So this was an absolutely intriguing paper, and the reviewers for Science thought it was intriguing too. You don't see all that much epidemiology in Science, but this was Frank Tanzer and colleagues, high coverage of ART associated with decline in risk of HIV acquisition. So that looked like this. The adjusted hazard ratio had lower incidence even at very modest coverage rates. And I'll tell you, when I read this paper, I just blew a gasket because I was just so amazed. It actually suggested that the modelers were all wrong. You didn't need 90, 90, 90. You could do much worse and still have an incidence effect. And so when people saw this, it gave a huge boost. HPTN 052, which demonstrated dramatically, almost elimination of transmission in a sexual partner if you treated them. And this observational study from a real world circumstance, it gave a huge boost in the arm. And this was in an environment where this young girl had an 80% lifetime risk of acquiring HIV. That's how intensive the epidemic is in parts of KwaZulu-Natal. You also had this sort of heat map, also from Tanzer and the group, in which they were looking at different parts of this one district, and vast distinction in terms of background viral loads depending upon where you lived, even in a relatively small environment. And I don't have to explain that to you in New York City, because we have all these small microenvironments where HIV rates may differ by factors of many factors, even in neighborhoods. And that's where they did their TASP study. By the way, these slides are all on the hard drive here, and borrow them. You know, I have permission from the authors to share them, so borrow them for your own teaching, whatever. These were the trial procedures. I won't go into detail, but they had homestead identifications, visits, home visits every 6 months, variety of dry blood spot and questionnaires, and then the 45-minute walk maximum to an actual TASP clinic, a treatment clinic. And you can see how modest this structure is, basically a container. That looks familiar to you, Wafa. We've used a few containers in our day. So, and then referring to the TASP clinic, repeating the test. So, looked like a pretty interesting and comprehensive approach. At the end of the study, you had a lot of knowledge of status, ART in the known HIV positives, not so good. Lower viral load for those on ART, pretty good. And then in all HIV positives, not so good because of this. So they didn't see a TASP effect. Nothing at all. Now, why didn't they see a TASP effect? I think I just showed it to you, but I'm going to show it to you again. If the modelers are saying that you're going to need about a 73% coverage with this sort of 90% of persons knowing their status, 90% of those who know their status being on treatment, and 90% of them being virally suppressed, if that's what the modelers say, who am I to disagree? I mean, you know, they're saying that you have to have a certain degree of coverage before you're going to see this population level effect. And they just didn't get there. They just didn't get there. The linkage to care was poor. So I don't mean to be dismissive of an important study, but it didn't test the concept. If these are your process indicators and you don't get there, that you have a negative study is no big shock, because you have a vast pool of people who are simply not virally suppressed. So that really threw doubt on the observational study of Tanzer from Science, in my view. How could you have had such a dramatic decline in incidence with modest coverage, but not have replicated that in the actual clinical trial. So I'm going to guess that the Tanzer observational study in Science was perhaps misleading, which epidemiology sometimes is. Now let's move to the, by the way, interrupt anytime, no problem. So let's move to, yes, please.
Do we know why they have such a low treatment rate? Because the rate of treatment is much lower than expected.
So, yeah, I was at Africa Center about a year ago, and I asked them these questions, and they felt that there still was a lot of community stigma. There were still a lot of people who were in denial. There was still a lot of people who were not going to walk 40 minutes to the clinic and have all their neighbors see them walk into an AIDS clinic. And they just weren't so successful with the linkage part. The people who came, I showed you that last 90 was pretty good.
Yeah.
So if you said, I'm going to go get treatment, adherence was good. And I can relate to this, the work in Mozambique, the work in Zambia. We could get people tested. It took a long time to break through, but after a while there was a testing normative. And if you came to our clinic, we could motivate folks based on their own self-interest and sometimes also care for their family and all the rest. But there was that gap of linkage. You know, yeah, it's an implementation issue. I think it's a psychosocial issue, stigma, a lot of what you all do for a living. Yes, you could say that. Yep. So the Botswana study, as Wafa will recall, we got to know this study very well in the early days, even though it ended up funded by CDC, but it was part of a family of studies that PEPFAR was co-funding. And we got to know this one very well because we synergized all of our questionnaires, all of our lab assays with this study. We were looking forward to HPTN 071, PopArt, possibly doing collaborative post-study meta-analytic work with this study as well as the study that ended up not going forward. So we got to know this group extremely well. The pair-matched community randomized trial in 30 communities in Botswana, and baseline and annual surveys, really, not that different from the TASP ANRS study. There were 15 intervention communities, 15 standard of care communities, and the standard of care was basically ART for persons with CD4 less than 350 because that was the standard in the country at the time, and was also the WHO standard at the time. But in the intervention communities, you had community mobilization, home-based and mobile testing, linkage to care, support, and expanded ART, making sure that the government clinics could handle this group of referred individuals. And first, they started expanding treatment here or to greater than 500 and high viral load, and eventually to everybody. And they also strengthened circumcision. So these were if those of you know Botswana, I don't know, what would you guess? 90% of the population lives essentially along this road, and this is a vast desert. So not surprisingly, these are the sites, but it was countrywide in terms of where the population groups are. And they were randomized sort of in pairs, so like with like. So if you had a quasi-rural site, you would be matched with a quasi-rural site. They also looked at background prevalence. This is something we did in HPTN as well. So they had a 20% cohort, a true cohort, and followed them over time. That's how they got their endpoints. So they had about 4,300 people in each group. They had excellent retention. Some of the reasons why people dropped out is there. And they did see a treatment effect. a TASP effect, I should say, treatment as prevention. And the surprising part of this was that Botswana was doing pretty well. So they already had much closer to 90 than any other country that I knew about. And so by the time this study got launched, there was a great fear among many of us who were tracking this field that the delta would be too small to be able to detect. You know, if you're doing pretty well, then to do a little bit better than that, you may end up with an inability to document that as a true treatment effect. But they did see a treatment effect, which was really interesting. People speculate why. Well, you can just sort of take from the TASP NRS that they couldn't get people to come in for care, but in Botswana they could. And I have a pet hypothesis. I don't know if I'm right or wrong, but I sort of think that if you're getting 85%, who are those 15% who are not getting tested or linked to care or suppressed? Could they be kind of like our 15%? You know how you spend, $1 million to reach 90% of the folks that are of interest, vaccine coverage, whatever it might be. Now you need another million to get the next 6%. And now you need 5 million to get that last 4%. These are precise figures applicable to all public health issues, and you can quote me. So, the point I'm making is we're very familiar with this phenomenon in public health, that we even call it the last mile. How to get to the last mile for polio eradication, how to get to the last mile for whatever, the guinea worm eradication, how to get to the last mile for HIV control. The people that have been left out may be left out for a reason. They may be marginalized socially. They may be persons with mental health or substance abuse challenges, whatever it might be. So I was speculating maybe this study got some of those people, and maybe those people were disproportionately influential in transmission, which often this last mile group is. I don't know. I'm just throwing it out there. I don't have the data, but it is plausible. And it was a great relief to have a major investment that actually showed that you could do TASP at a population level and make a population level difference, because we were investing a lot of money to see if that was going to be feasible. By the way, Milton mentions implementation science. These were clinical trials, but they were very implementation science centric because they were anchored in a real world condition. These were not optimized clinical trial conditions. Real world, can we do what we know will make a difference? We already know that treatment as prevention is theoretically going to apply to a couple or to a mother who's infected and a fetus. We already know that. But can we deploy it at such a level that we can knock the socks off an HIV transmission in a district, in a state, in a country? That was what these studies were really looking at. And that was a map of the incidence rates. You can see the size of the dots representing vast differences even in adjacent communities. And the proportion at the standard of care arm and the intervention arm, just a little bit better in the intervention arm, although they started out a little lower. So the delta here is the difference in differences. Getting up to nearly 90% of all HIV-infected persons with undetectable viral load was not bad. And that seemed to be demonstrably due to the program. Let's move to the search study that the UCSF folks did with their collaborators in Kenya and Uganda. This was, again, a TASP study, and they pair-matched 32 rural communities in these communities that were high incidence in Uganda and Kenya. study population, adolescents and adults. They had an interesting way of doing business. They couldn't manage home-based testing, which you do need a lot of money for home-based testing. Take it from Waff and me. You need a lot of money to deploy the community workers to go to every single home. And we got a lot of criticism in HPTN 071 because it was deemed too theoretical. You weren't going to be able to replicate home-based testing. But there's a meta-analysis from, I think it's from Helen Weiss at London School, that looked at all the testing strategies in Africa and their coverage rates. The only one that got to 90 was home-based. That was the only one that even came close. But the UCSF people, with their Kenyan and Ugandan colleagues, went with health fairs. And they had massive health fairs. And they did a lot of community mobilization in preparation for these health fairs. So they had mass testing in a health environment. And this patient-centered care model included non-HIV services, particularly hypertension, diabetes services. And they would start ART right at the health fair with the counseling and the clinics that were established or enhanced to provide follow-up, had flexible hours, which is not common in many parts of Africa, and mobile phone triage, reminders was all part of it. And then the health fair was only baseline in the control community, not annual, and the country's standard of care. They also looked at malaria issues, so it was a broader-based initiative. Very large study, 150,000 people. You can see the breakdown by HIV prevalence by country, much higher in Western Kenya. And you can see the breakdown in population with somewhat more than half in this 21 to 49 group, but a pretty big chunk, a quarter, who were adolescents. Hypertension was common, 20%. And this was a relatively stable population. Now stay tuned because we're going to talk about that in a minute with the HPTN 071. And half were farmers. Male circumcision was relatively common compared to many other parts of Africa, mostly because of high degree of success in Western Kenya. One of the most successful rollouts of male circumcision has been in Western Kenya. The Kikuyus have ritual circumcision as part of their culture, and the Luos all are mixed in with Kikuyus. They all have Kikuyu friends, and so circumcision is not very exotic to a Luo. So to say yes to circumcision is not as big a cultural lift. That's what Bob Bailey tells me as one of the reasons he thinks it was so successful in that part of the world. So here you had a mortality effect, which was really quite intriguing. Mortality among the infected persons was a whopping 21% lower in the intervention versus the control arm. And among all persons, including HIV uninfected persons, was a whopping 11%, possibly, related to picking up some of these very severe, hypertensives and that sort of thing. So I'm sorry this got muddled. I tried to fix it a minute ago and it still is muddled. So this was a negative study for the HIV incidence rate, and dead on negative. So we did not see a treatment as prevention effect in the search study. So we had, and I'll go back a slide. I also wanted to mention that TB rates and hypertension rates were also much lower in the study. So I would not want to call this a negative study by any means. There were all sorts of amazing results of this study that give us hope for chronic disease management in Africa. If we can screen, if we can offer services, people will avail themselves and people will reduce their risk, whether it's TB, hypertension. But we didn't see a treatment as a prevention effect. And that was disappointing because it was a very big study. Again, the awareness of HIV status was impressive. in both arms. So a chronic problem we have in prevention sciences is when you do too good a job in your enhanced standard of care arm. And, the classic example I love to quote is the Mr. Fit study, the multiple risk factor intervention trial in men in the 1980s, the bad old days when we did massive studies, 300,000 people in men only. And that was the same decade, the Reagan decade of I'm going to get fit, I'm going to get exercise. And basically, make a long story short, you had this intervention group, smoking cessation, exercise, hypertension control, et cetera. And then you had this control group. And at the end of the study, they didn't see much because the control group had done everything that the intervention group had done because of the background sort of culture shifting towards a more healthful culture. So many examples of where these big trials that take many years to launch and many years to conduct, you end up with your control group looking much more like that may be part of what went on here. I don't know. And by the way, all the investigators are getting together to study these things formally. So you're just getting from me Sten speculations. Ultimately, we expect some very good science to come out of these analytic partnerships between the various groups, and perhaps we'll have more definitive reasons why some studies seem to have found an effect, some studies didn't. And the ART eligibility was near universal within 1 year, so there was a background shift in the standard of care in the country. WHO changed its standards, Kenya and Uganda changed its standards, so they started treating everybody in the control group and being more aggressive in testing. And they had new infections from outside the community. They know that from some of their phylogeny work. There were some evidence of acute infection outbreaks that occurred, which may have been disproportionately working against the TASP, and a small subset of unsuppressed, which is what I was alluding to a bit earlier in my comments about the sort of last mile. So reduced HIV mortality, reduced TB incidence, increase in hypertension control, reduced annual incidence within each arm. So each arm had a reduced annual incidence, but no difference between arms. Now we get to the study that I worked very hard on at the beginning and WAFA worked very hard on at the end to succeed in launching this, I think, historic study, the HPTN 071. For those of you who are not familiar, HIV Prevention Trials Network. WAFA is the co-chair of that network at the present time and has been for six years. And I was the PI of the trial with Quraisha Abdul Karim in the previous 6 years. So she and I, WAFA and I, have been deeply engaged in this trial. So the intervention package was anchored around community health providers, and we called them CHIPs, community HIV care providers. And these were paired, often a man and a woman, working in the townships, working in the rural areas, working in the cities, to go into homes and test people and educate them about HIV. So it was health promotion, active referral, and retention care, promoting circumcision, PMT-CT, treatment and care for positives, and sexual health and TB services, condom provision. And the bottom line was universal test and treat. So treating everybody was the arm A. So this full pop art intervention, the CHIPS folks, the advocacy for circumcision, et cetera, and immediate ART irrespective CD4 count. Arm B was all of this, but ART initiated according to current national guidelines. And at the time, I and others thought this was a good idea because we weren't sure maybe this would get 99% of the benefit of this and would be cheaper and more acceptable to ministries of health, more replicable. I didn't have the crystal ball to see how quickly the expansion would occur. And so 2020 hindsight, this arm maybe not as critical. And then Arm C was standard PEPFAR, standard Ministry of Health in South Africa and Zambia. It was definitely enhanced care because PEPFAR was sinking a lot of resources, but we did not have the CHIPS and we did not have the outreach. We had about a 2,500 random sample from each of these 21 communities. a population cohort that theoretically was going to be 52,000, ended up closer to 40,000, and followed annually for 3 years. The background population was over 1 million persons, and these were the venues in the Western Cape. These venues here, for those of you familiar with Cape Town and the region, and then a much wider swath of Zambia, all the way from Livingstone here, all the way up to the Copper Belt up here, including Lusaka. So very talented teams from the Desmond Tutu TB Center at Stellenbosch and from an NGO research unit called Zambart that's nestled within the University of Zambia and largely run by London School of Hygiene and Tropical Medicine. So how to measure the impact of these arms? Our design was to look at arm A versus C and arm B versus C. So some of the coverage baseline stuff, 55,000 households visited. This is just South Africa, 55,000 households, 79,000 adults consenting. In Zambia, almost 100,000 households and 180,000 consenting. So you get a sense of the magnitude of the endeavor. And when we look at coverage estimates for the 90-90-90 targets, substantial improvements in coverage for testing, and then somewhat improvement for linkage and ART coverage, substantial improvement. So we did see some evidence that what we were doing was radically expanding coverage. So the total number of people in the population cohort, which is what we did to determine incidence, is follow this large population cohort, the subsample of about 2,500 people in each of the 21 target communities, and we had many more women than men, which you will see universally. If you do home-based visits, you're going to have a lot of absent men. And the ages were very similar across the arms. Again, a distribution that's not vastly dissimilar from search. And I think I put that in twice. And then the baseline ART coverage was about a third in the 3 arms, a little higher in arm B. So these were the study results, and this was a bit of a surprise. So we did not see, these are the paired communities, and these were paired based on similar status at baseline and similar HIV prevalence at baseline. And we did not see an overall treatment effect, a tier treatment as prevention effect, for the more definitive group, the arm A group that immediately offered treatment. Now, arm B in the middle of the study evolved to basically looking like arm A because the guidelines changed, the WHO guidelines, and we knew there was going to be a lag in the 2 countries picking this up, and it was very tempting as scientists to just go with what we had originally said, which is to follow the country guidelines, because with this lag of policy implementation, by the time they implemented it, we'd be done with the study. But WAFA and Debbie Birx and I think NIH should get credit for this. They really led the charge saying, no, we have to have highest ethical standards, and we know that the country is going to change their standards. People like Yogan Pillay told us that they were going to change their standards, but they had to go through a process. So we changed right away. As soon as WHO changed, we changed the protocol. So arm B is a lot like arm A, starting in the middle of the study. You follow me? I'm sorry, that's a little complicated, but the point is that arm B and arm A are not that different. For a little while, arm B didn't treat everybody, just treated people under a certain CD4 threshold, but quickly thereafter they treated everybody. And highly significant findings in arm B.
Can I ask you just for clarification? It seems to be pretty stunning that the differential between men and women
You explained it like men are at the house, whatever. But why would one expect population impact if there's such a great disparity in the number of men and women being treated?
Excellent question, Ron. So in the middle of our study, we recognized the dearth of men to be a crisis and potentially undermining the entire principle of the study. And we went into an overdrive to find men. We even negotiated with South African unions to permit people to work out of standard hours, to work weekends, to work evenings. And we did, in round 2, substantially expand our access to men. So the persons in the population cohort heavily overrepresented women, but we, in our interventions in the community, we did a much better job reaching men. But you are putting your finger on one of the great implementation challenges, is that if you access people who are accessible, you're not really doing the job. Does that sound familiar in New York City? So that last mile group is critical in HIV as it is in most public health challenges. But just follow me here. The more aggressive treatment, no difference, but the somewhat less aggressive treatment, a highly statistically significant 31% treatment effect. And if you combine the two groups by saying, arm A, arm B weren't that different, let's combine them, you get a significant 20% protective effect. So is this a negative study or a positive study or a mixed study? I would have much preferred this to look a little different myself, because it is frustrating when one has results that are disparate. And that's what it looked like. We had a non-significant 7% reduction in arm A versus C, but we had a whopping 30% reduction, highly significant, in arm B. How are we doing on time? Oh, I better. How are we doing on time? I'm going to skip this slide. Okay, so.
20 minutes.
Okay, 20 minutes. Well, I really, yeah, with questions. Okay, so viral suppression in arm A was actually higher than in arm B. So you go figure. We had a lot of community engagement. This was a real positive part of the study. The community bought in, they embraced the chips, they helped us at every turn. A lot of predictions that you're never going to get, this kind of thing going in a dangerous township or in a remote rural area, they were all proven wrong. People were on board. You can mobilize, and search showed this in a big way. You can mobilize. Botswana showed it in a big way. So at least we know that these things are possible. And we certainly learned that communities are not homogeneous. Uptake of interventions and choice of community engagements were influenced by a lot of other things happening in the community. And we had stakeholder analysis, adult community advisory boards, adolescent community advisory boards. We had a national CAB for both countries. We had community partners, platforms, district implementation management teams, national management teams. There was a lot of cooperation to get this done. And that included the ministries of health, the provincial ministries of health. PEPFAR was very cooperative because they helped with implementation resources. The Gates Foundation came in to support some of the work. PEPFAR even supported some of the science work, which they don't do research. So that was amazing. And the NIH came through. So it was a remarkable experience. PAPART achieved the first two 90-90 coverage, the high rates of testing and high rates of linkage. We did not have the money to do the clinical study that was postulated, so we didn't have good arm 3, the third arm, the viral suppression. We had to judge that from the population cohort. And from the population cohort, we did see high rates of viral suppression achieved in both arms A and B. And in this high burden setting in arm B, we found the 30%. We didn't see it in arm A, where it was delivered from the beginning, and it was a surprising result, not explained by lower rates of viral suppression. and we're working on phylogenetic analysis and qualitative research to try to throw light on this. The paper is in press. There's Waf and me in the middle somewhere, and you'll read that in the New England Journal, and you'll see a Columbia faculty member who has written the editorial as well. Okay, so why? Now this is just Sten talking. This is don't discount all the next slides. So this is community randomization in non-homogeneous environment. Could arms A and B differences just be due to chance? We had triplet randomization, 3 similar communities in the same country, and randomizing the triplet into A, B, and C. That only left us with 7 triplets. And small differences in communities between A and B could have distorted the findings. Maybe the most honest study would be the A-B combined analysis. But since that was not our prior analytic framework, we have to say that as a post hoc. Otherwise, we're not proper epidemiologists or biostatisticians. So the post hoc looked pretty good, but that's post hoc analysis. Could community randomization imbalance post-randomization? 38% of RMB participants were already on ART at baseline versus 32% in the other arms. Does that represent those 7 communities being systematically a little better off, infrastructure-wise, community participation-wise? Was our treatment effect more likely to succeed on that more fertile ground? I'm the only person on the planet. I asked Slim at dinner last night if he agreed with this, and let me just tell you, nobody agrees with this. This is just Sten. Waf is shaking her head. She doesn't agree with this. But I'm wondering if the immediate implementation of the full intervention in Arm A was too much too fast. I'm wondering if you actually gave a break to Arm B by letting them focus on chips, focus on, the first 2 90s, and not overwhelm their clinics, and then ramp up the clinic work, and that maybe there were some efficiencies. So nobody agrees with me. Pardon me? Yes, start with the sickest. They're the ones who are eligible. But at Arm A, you're kind of flooding the clinics all at once with a whole lot of people who don't feel sick. This last unreached 25%, 25% sort of an arbitrary number. It could be, different in different communities. Are they responsible for a disproportionate number of transmissions? And if you don't get at them, maybe you got at them a little better in the RMB community because you started at a higher baseline of immunosuppression. I don't know. And this also, I hated that this was a 3-year study because I always thought, it'll take us 2 years to figure out how to do the 90-90-90 right. And then that gives us only 1 year of follow-up to see if there's a treatment effect. What if there were 2 years of follow-up? Maybe you would see more of a treatment as prevention effect if you went out a year or 2. But we could not get the money to extend the study. It was already a small miracle that we were able to fund this. And ultimately, this will never be answered. We'll never know the answer to that question. And my postdoc and I, with some talented implementation scientists, and James Hargreaves, Dennis Nash, Donald Spiegelman, we have a paper in press sort of speculating on what I've just shown you. So it's not science, it's just interpretive. So we were funded by these sources, and I wanted to acknowledge the slides generously shared. I'm sorry I haven't given you a more coherent message that treatment as prevention clearly works when deployed at a population scale, but life's complicated. This is what the data show, and you can draw your own conclusions. Happy to take questions. Thanks. Please, go ahead.
So in your prior slide, you mentioned that the first bullet point that some folks had some disagreements with the first bullet.
Yeah, nobody agrees.
Or is it more that out of the 3, that's the least likely?
Well, there's no evidence for number one. We got better viral suppression in Arm A. So if we got better viral suppression in Arm A, on the face of it, this may not make sense. I'm just trying to come up with a comprehensive list of possibilities because the folks in these trials forged an alliance to look at post hoc analysis and try to see if they can tease out details in a sort of a meta-analytic way to see if they, using phylogenetics data, using qualitative data, to see if some rational explanations can whittle down this list of possible explanations. A lot of these would apply to search as well. A TASP is not so interesting because they just didn't link. 40% linkage of, nobody would suggest that you're going to see a treatment effect. You just aren't linking people to care, are not putting enough people on antiretrovirals, you're not suppressing enough people. So that one I would discount in terms of the value in the meta-analytic, but I think the other three are going to be very interesting. A lot of hands, let's go here and there and there. I'll look over here in a minute.
So what are the current thoughts related to migration? You were mentioning...
Okay, so migration is extremely interesting. We're in the middle of a big migration analysis, so stay tuned on that one. There isn't a lot of evidence that differential migration across the three groups, A, B, and C.
For incidence or viral suppression?
Well, for people coming and going, people who are never exposed to the intervention migrating in, people who may have been destined to seroconvert migrating out, all the distortions of not having a fixed cohort. Search had much better fixed cohort than PopArt did. And the HPTN 071 had, especially in South Africa, a lot of people coming and going. And that, you can sort of guess that would be a bit of a bias towards the null. Yes, Rob.
So according to your point two, the last time reached 25%.
Yeah.
In the area of vaccination, there's a lot of discussion about what herd immunity requires.
Yeah.
And different diseases require different
absolutely right.
coverage.
Mm-hmm.
So what do you think, or what does the evidence suggest would be the level of coverage necessary, not just ideal, but necessary to achieve the equivalent of herd immunity?
So Tim Hallett has a pretty good paper on this, his group, and that is part of the origin of 90-90-90. That was not an arbitrary set of three numbers cooked up by UNAIDS and WHO. That was actually based on modeling. And the trouble is that 90 times 90 times 90 comes up to 73%. That means 27% of the people in the community are not immunosuppressed if you reach the 90-90-90. If you reach 90-80-90, that's even a lower number than 73%. And if those 27% are systematically different, they overrepresent the parasitic taxi drivers, the truck drivers, the sex workers, people who are harder to reach in a standard program than these models may be wrong. We may need 90-90-90 in high-risk populations as well as low-risk populations. And starting to think that way, we have to segment populations, do an especially good job with the especially relevant transmitters.
Actually, along the lines of the last two questions, I'm curious if you have, you mentioned sort of phylogenetics as one potential source of this, but if you have sort of social or behavioral data about potential differences in the structure of sexual contact networks within these communities that might elucidate a difference if there are sort of more clustering in RNA or something like that.
There are extensive behavioral data, including some nested behavioral studies that are going to be emerging in the near future from 071 in particular. We had somewhat more resources than the Botswana or Search does. Search did their work mostly with an R1, a big R1 from NIMH, and then some Gates support. Botswana mostly had PEPFAR money through CDC, but not a lot of additional support. But we were able to broker resources from NIH, from Gates, and from PEPFAR, and we were able to do more of these behavioral sub-studies. So stay tuned. Now, how good a job we can do with formal network analyses, Wafa, I'm not sure.
I don't think we have.
No. No.
But I think looking at behaviors across Arm A and Arm B, there really was no
Yeah.
difference.
Yeah.
So like,
Yeah.
and there were lots of different ways of
Yeah.
asking about sexual behaviors, numbers of partners, companies.
Mm-hmm.
I think again, we're at a loss as to why
Yeah.
this affect this finding.
Yeah.
Because
Well,
there was no difference.
we're still learning. I'm going to go here and then back here, but there was a hand. No? Okay. Go. Oh, yes. Go ahead. Yes.
So I think a lot of these trials are really testing kind of referral to or initiation of treatment,
Yeah.
not necessarily treatment adherence. I wonder if there's a way to utilize, say, like an instrumental variable analysis to actually test between these communities if these mechanisms promote treatment adherence and among people who are adherent to see a difference in kind of reduced incidence.
Yeah, we were able to assess viral load within our population cohort in 071. And that did give us some indication of adherence. So it was pretty good. It was pretty good. I think the greatest challenge is what we saw in the TASP trial. And by the way, we saw that in HPTN 071 too. After our first round, we were very self-congratulatory about our treatment coverage. And we were horrified by our linkage coverage. And we had to go into overdrive for round 2 and put a lot more resources in because it wasn't enough for the CHIPs, these community HIV care providers, it wasn't enough to refer them. We had to take them. I mean, you know, there had to be a much more aggressive approach to linkage that we were, I don't know if we were naive at the beginning. Naive is a hard word to say because these are very experienced places, but we were overly optimistic, I'll certainly say that. And so what TASP found at the end of the study, which was really a shame because there's a lot of resources and what did we learn from that study, but at least we were able to do mid-course corrections. And I think the search data also, the diminution was in the linkage. So I think folks in Africa who actually have an opportunity to get to a clinic and talk to a nurse, talk to a doctor, learn about the value of antiretrovirals, we've done better. We've done well. Do you remember Administrator Natsios from USAID about 20 years ago saying that there was no point to a PEPFAR type initiative because Africans are not going to take their drugs because they can't keep time or some racist horrible thing that he said. That was Ron remembers that. Yes, please.
So, in Rakhine, you see people not only migrating, but just moving around all the time. 70, when you go to the cohort, 30% of people are somewhere else.
Yeah.
And so you have to track them down or whatever.
Yeah.
So I'm worried about some sort of saturation effect. If you have isolated villages, isolated communities, and all the adjacent communities where people might be picking up an infection are not part of this, your intervention. I mean, I would think that's a huge potential diminution of your treatment effect. Because the people you're getting, whereas the clinical trials work because you're specifying individuals and tracking them specifically, but you're not doing that. So, I mean, what do you think there? Is there?
I agree with you. I agree with you completely. I think that one of the great challenges of sort of demo projects in this space is that, sure, we have the luxury of being able to take these triplet communities and we can make sure they're not too close and they're similar baseline, et cetera, et cetera. But in a real world circumstance, you're going to need to deploy that nationwide. You're going to need to have much broader coverage if you're really going to see sort of a nationwide diminution. And in some countries, of course, cross-border issues are very prominent. You look at Burundi and Congo, and I mean, just the cross-border stuff is just massive. And so I feel like there really is a lot of challenge in this concept that treatment as prevention is a scientific reality. We know that we can reduce infectiousness to others. Its deployment in a real world circumstance, we're not there yet. And that's one of the reasons.
You know, we had Slim here a few months ago, and it really was, I mean, he felt that South Africa has been a failure in terms of all the money which has been put in and all the trials. And it really is not worked. It was quite depressing, the way he laid it out. Do you agree with that?
Well, I have some insider knowledge just because I have friends working in Pretoria, and you know, in some ways, South Africa is doing worse today than they did 2 years ago. So it's been an amazing, immense challenge. The system is not efficient enough to see the full benefits of the inputs, and there needs a lot of systems reform. Wafa.
Yeah, just a couple of thoughts. I mean, again, I feel like whenever we talk about treatment as prevention, and I know that's the focus of the talk, we shouldn't forget the value of treatment as treatment for people who are themselves have HIV. So, I mean, treatment has saved millions of lives, including in South Africa. So I think just sometimes I feel like it's kind of forgotten in the equation. The individual, if they stay on treatment, then they get individual benefits. Although it's been hard to show to these clinical trials the value as prevention, I think on the other hand, there's no doubt that treatment as treatment is life-saving. Mm-hmm. I mean, I was wondering if Nina was going to mention it. Another source, Sten, is are the findings from some of the FIA studies, the surveillance at national level, like the surveys we've done, and she has actually led in Swaziland, Eswatini, where they did 2 population surveys 5 years apart. And this is a whole national survey. There was a clear association of an increase in viral load suppression at a national level with a decrease in HIV incidence. So it kind of gives another proof of concept that at a national level, if you can scale up the programs, you actually can show that link between national viral load suppression and decreasing incidence. So I think, although these studies are mixed findings, there's other evidence that I think is encouraging that certainly has an impact on transmission.
Excellent point. How much time do we have? 2 more questions? Last 2? Yes? Go ahead.
So I have a question about whether this kind of goes to the clustering of transmission and infection, and I'm wondering, have you looked at which populations, like subpopulations of where the new HIV infections are happening post-intervention? So I'm wondering, like, if it's all women who are accessing the treatment, then you're going to see effect in their male partners. You're not going to see effect in the young women who their older male partners are not utilizing the intervention. So I'm wondering maybe it worked for certain people because of who you're targeting.
Right. Well, we did not have a full population assessment. We just had a population cohort that was followed over time. And I think we are doing some microanalyses of incidents now, but these communities are not vast. So I'm not sure where we'll be able to go with that. But it's a good idea. It's a terrific idea. And maybe some of our phylogenetic data will be very helpful when we map the phylogenetic data and look for transmission clusters. You know, imagine that you have an acute outbreak in an Arm A community. Is it plausible that one event could blow away your treatment as prevention? The answer is yes, it is plausible. So the phylogeny will be helpful. The last, yes.
Did any of your studies look at development of ART resistance? Is there an increased incidence, and if so, how should that be managed?
Yes. So the phylogeny work happily gives you a definitive resistance assessment, and we should have that within a year. Yeah, within a year. We would be cautiously optimistic in the sense that these days we are using triple therapy in as few pills as possible. Certainly, if somebody takes it one day, doesn't take it the next, takes it, doesn't take it, you can develop resistance. But since we had highly favorable viral suppression rates, I'm going to go out on a limb and say that perhaps resistance is not going to be a dominant theme in the study. Again, if we studied it for another 2 years, and if we saw that some people had sort of treatment fatigue and then started not to, but we didn't have the money for that tail of the study, and perhaps we won't see much resistance, but I still won't be able to answer your question. Well, thank you very much for the invitation.